Ma'am, can we start?
Is it better now?
Oh, yes, ma'am. It's better.
Yeah.
Yes.
Yeah. Okay. Yes.
Kiran sir, can we start the recording again? Good afternoon, everyone. iTech India welcomes all the participants for today's NDLS session. Today's topic is mental health issues among PLHIV, and the speaker is Dr. Maithili Umate. Dr. Maithili Umate is currently working as an associate professor with the Department of Psychiatry at GGMC and JJ Hospital, Mumbai. She has extensive experience of working with PLHIV with psychiatric and psychological issues. She has published many papers in international and national journals. We welcome you, ma'am, for today's session and request you to start the session.
Thank you. Yeah. We'll start today's session for mental health issues amongst persons living with HIV. The topic is of importance because we need to first create awareness of mental health issues which are faced by people living with HIV. Often these are ignored and that creates a problem. Also, what I feel is the end of today's session, we should be able to even identify common mental illnesses and to understand which are common psychiatric side effects of antiretroviral or AKTs. So let's come to the background. People living with HIV, they are prone to psychological ailments because of opinions and experiences regarding HIV in their surroundings. They may also face multiple types of psychological issues like, say, depression, anxiety, internalized stigma. Any such issue can significantly hamper adherence and mental well-being. Various studies have shown that mental health issues and psychiatric illnesses are more common in children and adolescents living with HIV as compared to general population. Also, we can see this trend also in adults as well, where certain mental illnesses are found much more in people living with HIV rather than their counterparts. The prevalence which is stated is around 6 to 12% of mental health conditions are seen in children and adolescents. In fact, the NMHS, that is the survey, National Mental Health Survey, it showed a prevalence of 7.3% in children and adolescents between 13 to 17 years of age. Overall, 8 to 13% of children are estimated to need mental health services. So it is much more important to screen children and adolescents for mental health related issues.
Excuse me, ma'am. Ma'am, can we quickly run the e-poll for pre-test?
Yes, sure.
Yeah, thank you, ma'am.
Yeah.
Kiran sir, can we have the e-poll, please? The pre-test questionnaire is now visible on your screen. All the participants are requested to please attempt all the questions. Please scroll through the questions and answer them. We have 5 minutes for the e-poll. Requesting all the participants to please take the pre-test. The questions are visible on your screen. Thank you, everyone. Ma'am, we can continue the session, please.
Yes. Yes, so the relationship between HIV and mental illnesses, it's a very complex relationship. Of course, it is the neuroinflammation, the psychological and the neurological comorbidity, which leads to a lot of interactions amongst each other. Sometimes mental illness itself predisposes or is a risk factor for HIV exposure, like say drug use is often associated with risky behaviors, which predisposes a person to develop HIV. Additionally, people with HIV, due to the illness, could have other biological issues, could have chronic inflammation. There could be depletion of tryptophan, which could lead to them developing mental illnesses. Also, there is a role of opportunistic infections and role of medications, ARTs and AKTs, which can further give rise to development of mental illness. So what are the challenges that we face? That for persons living with HIV, if additionally they have a comorbid psychiatric disorder, or say if there is a history of substance abuse, homelessness, stigma, discrimination, or social isolation, this additionally adds to the burden and often leads to issues in treatment adherence in which people are not compliant with their treatment. This very often, remember, comes with hopelessness, which comes with many mental illnesses, wherein a person feels that there is no sense in taking the treatment. And this is a very common reason why people with mental illness often skip their ART drugs. The additional role of certain psychosocial stressors or psychological reaction to diagnosis or due to further events like say worsening of their condition can further lead to issues. So which are the mental illnesses which are commonly seen in persons living with HIV? Substance use. If you catch even nicotine, then ideally that is the most common. That is seen in 40 to 74%. And the incidence is much higher, say 2 to 4-fold higher than in the general population. Otherwise, amongst the main mental illnesses, depression is the most common, which is seen amongst 22 to 50%. That is a 2-fold increase than the general population. It is much worse for bipolar mood disorders, which is a 10-fold increase. Other illnesses which are common are anxiety disorders and sleep disorders. Psychosis is also seen more commonly. The findings of PTSD and dementia are also more common in those with HIV. Now let's go to the side effects of medications. Amongst the antiretroviral therapy, efavirenz is the most common, which leads to depression or suicidal ideation. Psychosis is also sometimes seen. Though I believe in the recent regimen, efavirenz is not used so commonly. However, if it is used and there is a comorbidity of mental illnesses, then it is recommended that the medicines be withheld for the time. Excuse me, is there a disturbance? Am I audible clearly?
Ma'am, you're audible. It's clear. No disturbance.
Okay. Other ARTs are not so commonly associated with psychiatric side effects, and these are quite rare side effects. But I am mentioning these for you all to keep in mind, because if there is a patient on ART who's recently developed any behavioral changes, this is what you should look out for. That is, you have doravirine, where suicidality can be seen. In case of zidovudine and abacavir, there could be a psychotic episode or manic symptoms. In case of raltegravir, insomnia, depression, and suicidality could be seen. And manic symptoms could also appear with didanosine, ganciclovir, and stavudine. Amongst other medications, I would specifically like to mention INH and cycloserine, which are used in the AKT regimens. With them, INH-induced psychosis is a common side effect. Even cycloserine, it is commonly seen that patients on cycloserine develop depression. In fact, patients to be started on second-line AKT, often a psychiatric fitness is taken before it is started. Now, let's see which are the common mental illnesses which are seen in people living with HIV/AIDS. The first one I would like to mention is actually a neurological condition, that is a delirium. It's a medical condition. I would like to mention this because this is very often confused with delirium, with depression or dementia. That's why I'm taking this topic first. What happens in delirium is the person has a confused sense of sensorium, which is often fluctuating. So intermittently, the person could be could be having lucid intervals, and intermittently could be getting confused. Now, delirium are of two types. One is hypoactive and hyperactive. Hyperactive is generally not missed, because what happens in hyperactive delirium is the person looks obviously very delirious, confused, talks irrelevant, and often has delusions and hallucinations. So, and they could be disruptive. So typically they would pull out their IV lines, or they would get confused and behave in a manner which everybody would notice that the person is confused. Hypoactive delirium needs to be seen first because it is often confused with depression. That is because in hypoactive delirium, often the person appears apathetic, morose, it appears very silent. People can mistake them for being depressed. But if you actually talk with them, you will see that their attention and concentration is impaired. So how do we treat this? The treatment is mainly treating the underlying cause which is causing delirium. And some strategies are very simple reorientation therapies, like say in front of the bed, if a clock or a calendar is kept. These are stimuli which make them realize what is happening around. Simply by talking with them, greeting them good morning or good evening, or reminding them that yesterday was Dasera, that makes them a little oriented and less confused. Now we go to the neurocognitive disorders, that is the HIV-associated neurocognitive disorder. This is again a neurological condition which is now seen less common since patients are taking regularly ART. However, patients who are non-compliant with ART or who have not yet started ART, neurocognitive symptoms are pretty common. The causes of which could be a low CD4 count. One of the main things is the CSF viral load, which correlates with the severity of the neurocognitive symptoms. That is, neurocognitive symptoms means it could range from a simple or a minor cognitive motor disorder, that is a common forgetfulness, to a wide range of HIV-associated dementia, where the person could be having a lot of confusion and forgetfulness. So in early symptoms of the disease, it will be seen that the person will be forgetful. They might become slow. So the family members might complain that they are taking a very long time to take a bath or do their daily task. They may appear very inattentive or distractible, and they may find it difficult to change topics. As this illness progresses, the memory impairment becomes quite prominent. And you could get apraxias. Apraxias, that is, they could find difficulty in performing daily tasks, which could be simple. So, they might appear a little confused while even using like combing their hair or buttoning up their shirts. And the person could be having difficulty in talking, that is dysarthria. They could have difficulty in balancing, ataxia. Here I am mentioning because they sometimes get confused with psychosis or depression. That is because a lot of people with dementia often have apathy, they appear depressed, or they have sleep disturbances. Sleep disturbances, rather than insomnia is classically altered sleep-wake cycle. So typically they will complain in the daytime, the person will keep sleeping, and the night time they will stay awake, and often they keep doing repetitive activities like arranging the cupboard, keeping the utensils again and again. So the family members might think that they are having a problem in their behavior or appear psychotic. For this, the best part is that there are certain neuroimaging tests or neuropsychological testings which can make us realize if this person is having neurocognitive symptoms. The treatment mainstay is medications, though the role of stimulant medications like atomoxetine and modafinil is debatable. However, memantine and donepezil appear to be good drug of choice. Now I come to the main and the most common disorder which is seen, that is depression. It is seen in 4 to 40%, and it is much more common in women. It is often seen in the symptomatic stages. Sometimes you could see an adjustment disorder, that is people having problem when they come to know their diagnosis, or later on in the illness as they get some stressful life events. Now, to remember, depression itself could be a risk factor for HIV, as it often has an impact on behavior. There is an increased drug use seen. There is exacerbation of self-destructive behaviors in depression. Now, HIV illness itself could lead to depression, as the person gets diagnosed for the first time, as the illness worsens, or because of stressors which come as a part and parcel of the illnesses. And because there is a lot of social isolation, demoralization, loss of support system, stigma, the person may have any lack of confidence. They may not know whom to talk to when they are having certain issues. This itself also leads to depression. Additionally, because of HIV itself, there could be a direct injury to the subcortical areas or changes in their deep gray structures, which lead to people developing depression. Now, why is it important to identify and treat depression? See, depression is one of the top 3 disabling illnesses, which leads to poor quality of life. Remember, it's a chronic illness, long course, multiple relapses, that people once with depression is very likely 50% get a depressive episode again within the next 2 to 3 years. And most importantly, why is it important in persons living with HIV? Because this is one factor where people develop hopelessness. And once a person develops hopelessness and they feel there is no sense in doing anything, that directly impacts their treatment, compliance, or utilization of services. Because once you start feeling that nobody can help me, then the help-seeking behavior automatically decreases. And this is one of the key features in your practice. Whenever you are seeing people who become non-compliant with their treatment or who are very irregular with their treatment, please do screen for presence of depression. It is quite likely that the person could be suffering from hopelessness and could be having an underlying depression, which is untreated, and that is leading to a worsening of the condition. So effectively, when people are identified as having depression early and they are treated in time, the service utilization is better, the prognosis of the illness is better, and the monthly cost of healthcare services, it is shown in studies that the monthly cost of healthcare services comes down. So how do we understand a person is depressed? Now the thing is that you need to understand, we often use the word depression very lightly in a layman. Like typically we say, "Aaj ghar pe kisne data, to main to depressed ho gaya." Now that, understand, sadness, common sadness is different from clinical depression. Depression is an illness, whereas sadness is a feeling. So for a person to be called as depressed, he should be having at least 2 weeks of symptoms, and this should lead to some changes. So a person who is feeling sad, he will be having a pervasive sadness. What do I mean by the word pervasive? Pervasive means if you ask them, कैसा लगता है? They say, अच्छा नहीं लगता है, दुखी लगता है. तो दिन भर ज्यादा दुखी लगता है कि अच्छा लगता है? So typically the answer they will say is most part of the day. That is, ज्यादा करके हमको दुखी लगता है. So pervasive is a key term when you are defining depression. That is, it is not just related to a stressor. It is not just that when they are thinking that, okay, I'm having an illness, what if people come to know, or how will I do with the financial problems I'm facing? But later on, when they go about things in the day, they feel fine. That is not clinical depression. For clinical depression, the sadness has to be for most part of the day, if not entire. And secondly, a most important symptom is decreased interest on pleasure in especially previously pleasurable activities. So you ask them कि पहले क्या अच्छा लगता था, तो they might say हमको टीवी देखना अच्छा लगता था, हमको दोस्तों से बातें करना अच्छा लगता था, पेपर पढ़ना अच्छा लगता था. So you ask them, do they enjoy it like before? And many of them will say that I just go about my daily activities like a chore. I mean, I don't feel, I don't enjoy it at all. I do it just like a responsibility. Now, apart from these two classical symptoms of depression, we have other symptoms. That is changes in appetite. So the person will suffer weight loss or weight gain, will have problems in sleep. The person will become slower. That is psychomotor retardation. They will feel a complete lack of energy. They might feel worthless and they might have guilt feelings. I am responsible for my condition. They could have disturbances in concentration level. They could feel like dying. Now, this is different from or death feeling where a person is thinking, I have a major medical illness, which I may die. It's not that. It's about dying, that I want to die. Or life was better off if I was dead. They could also suffer from poor self-esteem. For diagnosis, at least 5 symptoms should be present. Amongst these, I want you to remember that certain symptoms are overlapping with HIV. That is changes in appetite, sleep problems, energy changes, slowing down. This is common in HIV. So classical, what comes in depression, which doesn't come in HIV, feeling guilty, okay, or feeling hopeless, or feeling sad. The energy in depression will be, they will say, I don't feel like doing anything. Where a person with HIV who is having problems with lethargy will say, I don't have the energy to do things. So that is the crucial difference that you need to see. So some people may say, I feel sad. Some might feel, I don't feel anything. I mean, I neither feel sad nor happy. Some might say that sirf chidchid hoti hai, so they are irritable. This is much more common in children and adolescents. And atypical symptoms will be typical are decreased appetite, sleeping less. Atypical will be having a weight gain or increased appetite or hypersomnia. The other features are, of course, worthlessness, difficulty in concentrating, thoughts of death, or suicide. Other symptoms which are common is anxiety, which they will experience. Sometimes it may happen that family members will complain on the patient. So you look for other features also. Like typically they will have a diurnal variation in mood. What do I mean by diurnal variation? Classically, they will say that subah uthte hi kharab lagta hai. So the mood, the sadness or the low feeling is worse in the morning when they get up, and it gets better as the day progresses. Other symptoms are not so common, that is catatonic or psychotic features. Now, in children, who are having depression, they might face with not feeling like going to school. They will say typically before school time, they will complain, pet mein dard ho raha hai, sar dard ho raha hai. They might refuse to go to school. Some might even cling to the parents or cry. Typically, they will hang on to the caregivers. Sometimes ask them not to go outside the house, not leave them alone. Sometimes their grades will drop down. They will score lesser than before, or they might even fail their exams. And sometimes they may refuse to go out and play with friends and prefer to stay at home and watch TV or play on the mobile phone. In case of adolescents, again, you might have a drop in grades. In adolescents, rather than feeling sad, very often we see adolescents who complain of being irritable. So they might have acting out behavior. So what is acting out? So they will act in a manner which is more rebellious. So they might use drugs. They might start keeping bad company. They might be irritable and back answering maybe elders, teachers, or any other authority figures. Or they might start indulging in increased drug use, alcohol, tobacco. Cannabis is typically started in the adolescent age. Or they could also run away from home and indulge in stealing or any other antisocial activity. They may even indulge in sexual promiscuity. Old age. Again, depression in old age is often overlooked because a lot of things it is misattributed to ageism. That, typically as people age, they complain of feeling low, lethargic. So it is often dismissed. We need to ask them how they feel. Because old age, as as compared to young age, they are more likely to actually commit suicide than make an attempt. So what are the risk factors? Anybody whose family member has recently died, or any friend who's recently died, especially from the same condition, or they have just come to know about their seropositivity, or they have just worsened in some manner, or if they have relapsed, their mental illness has just relapsed. So a depressed person or a psychotic illness has just relapsed, or they are having some difficult social issues, or they are having some financial issues. People who are getting confused in terms of delirium and dementia, they are also at a risk factors of self-harm. Or any recent change in behavior, like they become quiet, they make a will, or they speak about life after their death, or they start naming people that after you, after me, my assets should be divided in this manner. So that these all should be recognized as red flags. Becoming withdrawn, talking about death, making arrangements, talking about others living without them, or switching to say mania, like in which they say that now my illness is cured, I have found a cure and I'm going to become all right. Or if they actually talk about suicide. Now the thing is that remember, research has shown that 75% of people who commit suicide have visited a family doctor in the last 1 month. So people do seek help. It is just that we don't ask. So this is something we need to find out. Also, if a person has started increasing their drug use, smoking more than usual, drinking more alcohol than usual, you should consider that they could be having a problem. Now, depression, why I'm emphasizing so much? Because this is a treatable mental illness with a very good prognosis. And there are very good medications available, selective serotonin reuptake inhibitors like say fluoxetine, which is available from 20 to 80 mg, amitriptyline between 25 to 150 mg, SNRIs, that is serotonin norepinephrine reuptake inhibitors. Amongst these, fluoxetine and amitriptyline are preferable. They are easily available. They have very less drug interactions, and they give very good treatment response also. Most of antidepressants are quite effective. For the medical officers also specifically, I would want to say, there is a very good molecule called as mirtazapine, which causes sedation. So people who are depressed and having sleep problems, maybe mirtazapine can be a good molecule. In terms of drug-drug interactions, SSRIs like escitalopram, sertraline, these are safer drugs. However, if a person is taking nefazodone, you need to be careful and preferably avoid fluoxetine. Other treatments apart from medicines is group therapy, cognitive behavior therapy, supportive psychotherapies, and of course the role of yoga and meditation is quite useful in treatment of depression. So again, coming to drug-drug interaction, as I told you, amitriptyline, fluoxetine are safer, do not have much drug-drug interaction with the typical antiretrovirals. However, for amitriptyline, you need to be a little careful because it prolongs the QT interval in the cardiac thing. So ECG monitoring will be recommended. Now, I would like to talk about this questionnaire, that is PHQ-9. PHQ-9 is a very easy to use questionnaire, and it's a approved screening instrument for depression. And it is available in local Indian language, that is, it's available in Hindi. Ideally, according to guidelines, it is said that before you initiate the treatment, that is ART, and every 6 monthly, it should be used as a screening tool. I will strongly recommend this because this is not something that even the counselors in the ART clinic can administer. This is even a self-rated questionnaire. So even if you are having a very busy day in the clinic, for a regular follow-up, timely you can ask them to fill in the questionnaire and give. It is very easy to score. See, there are 2 crucial questions, very short, which you ask. That is, in the last 2 weeks, have you been bothered by feeling down, sad, or hopeless? And also, if you are being bothered by feeling little interest or pleasure in doing things. Ask these 2 basic questions. If yes, then you can apply the entire screening scale, which is rated from a 0 to 3. That is not at all. On some days, more than half the days, and most of them. Where the symptoms, if you read, are the typical depressive symptoms. Like koi cheez mein ichha nahi hona, udaas lagna, नींद लगने में तकलीफ होना, ताकत नहीं है ऐसा लगना, भूख नहीं लगना, खुद के बारे में बुरा लगना या लगना मैं एक फेलियर हूँ, कोई चीज में ध्यान नहीं लगना, या बहुत काम धीरेपन से होना, और ऐसे लगना कि बेहतर था कि मैं मर जाता. See now, if you see, there is, I have not shared here, but I can share with you later. There is a PHQ-9 available in Hindi, which I think most of you all will be comfortable in using as a screening test. Here, after scoring this, you get scores. Okay, for a score 4 or less, depression is quite unlikely. For a score 9 or less, it is mild, for which the counselors and the ART clinic can take over and provide supportive counseling, and you can monitor. Ideally, if efference is going on, you can consider substituting it with another molecule. It is when the scores are 10 and more, that is, the person could be moderately or severely depressed, where not just counseling, but also you should consider referral to a psychiatrist. Okay, and again, if efference is there, you should substitute this for another molecule. So what are the key supportive messages for a person with depressed? For psychosocial support, you could explain about depression. Since it is a very good treatable condition, you should assure that it can be managed. Okay, feeling hopeless, worthless, they are a part of depression. You explain to them कि ये proper दवाई और इलाज से ठीक हो जाएगा. You identify which of the family members की वो मदद ले सकते हैं, who could be their focus of support, and you involve them as necessary. Because why I'm saying this is important, because very often when a person is depressed and he starts feeling hopeless, they will not come for treatment. That's why you involve a family member, a responsible family member early. You can at least push them to take medications, to come to you for follow-up. You involve their peers, if possible, involve in community support groups. You ask them, for the patients themselves, ask them to continue the medicines and to do activities which they enjoyed before, if not now. Encourage them to take part. Initially, they may say that, पहले मुझे क्रिकेट देखना पसंद था, अभी कुछ मजा ही नहीं आता है. But देखो, कोई बात में खुद को involve रखो. Ask them to get a proper sleep. See, now it is important. You can't make a person go to sleep. Explain to them that try to catch on sleep, especially control the screen time. In India, this is a problem. A lot of people come back late from work, so people eat late. They watch TV, or maybe then they just screen through their phone. And it's normal for people to sleep by 12, 1, or even 2. Encourage them to keep a proper sleep schedule and sleep in time. If they are not getting sleep, tell them not to force themselves to sleep. They have to lie down and just rest. Whenever sleep comes, it's okay. Ask them to go get a lot of physical activities, go for a regular walk. They can even contact the local authorities if there are any thoughts of self-harm. There are even a lot of self-help or free helplines also available, which can be availed if a person is having suicidal thoughts. Help them to identify their stress points, discuss them, okay, and how they could solve them. And stress management like meditation could also be tried. Now, coming to the second mood disorder, that is bipolar. Though this is rare and not seen as common as depression, I want to tell this because a lot of patients with depression can switch to bipolar. Remember, bipolar is bipolar, two poles. So their one pole is depression, other is mania. So sometimes patients with depression later on develop mania. So whenever a person suddenly starts off talking of getting a new cure and they are all fine, or they suddenly become very euphoric, it should act like a red flag, and you should get their mental health evaluation done. This is also treatable with the help of mood stabilizers and antipsychotic medications. Treatment, of course, these are the anti-epileptic drugs which are used as mood stabilizers, that is divalproate, lithium, carbamazepine. We also use atypical antipsychotics like olanzapine, risperidone, quetiapine. These are good molecules. Coming to the next disorder, that is anxiety disorder. Anxiety disorder, keep in mind, because this is often associated with less utilization of services. See, a person who is having agoraphobia, that is a person who is having fears of, say, crowded places, or having fears of what if something happens when they go out, they may not even come to the clinic for taking the treatment. So their illnesses should be identified and treatment. This is more often seen in people who are single, who are unemployed, or who are having poor social support. Other anxiety disorders are generalized anxiety disorder. That is a person having anxiety about day-to-day events. So they will typically say, रोज की चीजों को मैं चिंता करता हूँ, आज क्या होगा, कल क्या होगा, आज की चीजें कैसी होंगी. Or there is post-traumatic stress disorder. This often comes in relation sometimes to the diagnosis itself. After getting a diagnosis, they develop acute stress reaction and later on develop a post-traumatic stress disorder. This is also seen in women who, after a case of trauma, due to some traumatic condition, later on develop post-traumatic stress disorder. So what happens in this? After the trauma, they continuously relive that event. Like a person who would be sexually assaulted, who would continuously remember that event or get images or flashback or even get nightmares about it, which would make them feel very anxious and upset. This is again associated with more of using avoidance of situations. They could use more drugs, that is alcohol and other intoxicants. Treatment of this is again anxiolytics and antidepressants. Psychotherapy is also very useful. One more anxiety disorder I would like to tell is panic disorder. In panic disorder, what happens is the person gets an acute panic-like anxiety. So they will say typically heart attack jaise lag raha hai, getting a lot of anxiety, sweating, chest pain, and they feel as if they are about to die. Now they very often visit the casualty repeatedly because the panic is so acute and severe that they do not think this is a mental health condition, and they often come to casualty. All investigations come normal, and that's when we think, okay, this is an anxiety disorder. This is again treatable with medications and psychotherapies. Now, is psychosis. Psychosis itself can be a risk factor for infection, or a person with psychosis is very likely not to take the treatment because they feel nothing may be wrong, or they may feel there is something wrong with the treatment, and they may indulge in behaviors which will put them at higher risk for either developing the HIV or spreading the HIV. So again, psychosis could become also by some drug uses, like say some AKTs, that is specifically INH, is associated with psychosis. Also, other antiretrovirals, though it is less likely, but anytime ART is introduced and a person develops psychotic feature, or if the dose of ART is increased and the person develops psychotic features, you should consider this is drug-induced or medicine-induced psychosis. Again, patients with psychosis have a more difficult time because they also already have our medications of antipsychotics which are ongoing. Additionally, patients with psychosis are more likely to even indulge in other drug uses. Now, one of the main disorders, which is again a part of mental health, is substance use. Remember, substance use itself is a vector for spread of HIV. That is, 30% of IV drug users are found to get infected with HIV. Also, amongst people living with HIV, IV drug users are a significant chunk who have poor prognosis because of poor treatment adherence and other comorbid psychosocial factors. Now, which are the drugs which are commonly used? The most common is, of course, nicotine. Next to that is alcohol. In India, use of cannabis and opioid is very common. Also, other drugs like amphetamine, cocaine, inhalants, and other club drugs are used. Now, why this is a problem? Because often people with substance use present with a triple diagnosis. Triple means they already have HIV, they have substance, and they have a third illness, which is another psychiatric diagnosis apart from substance use. So treating them is often very challenging, and they often have poor prognosis. So they typically have increased drug use or abuse, and they are very likely to relapse. Like even if they start abstaining from a drug, they very quickly start using the drug again and again, becoming non-compliant with treatment, and they become prone for opportunistic infections. So because of these poor health outcomes, poor adherence, when such patients are identified in your clinic, it is important for you all to refer them to mental health services because they often need an integrated approach towards treatment. So whenever they come to you, it is seen, okay, studies have shown that whenever there is a discussion between patient and provider about their substance use, there is a greater likelihood that they will start treatment, they will stay maintained on treatment. So whenever these cases are there, try from your side to talk to them and discuss about their current drug use. So what is the goal of treatment of patients with substance use? First will be to reduce or stop drug use. See, now this is a myth. There are a lot of people who take drugs who will tell you कि नहीं doctor अचानक से तो बंद नहीं होता है, थोड़ा कम करेंगे ना. It doesn't happen that way. You need to ask them to stop. There are good anti-withdrawal line of management available. It is best to ask them to stop. Secondly, we try to reduce their high-risk behaviors. So we have detoxification treatments which help them overcome the withdrawal side effects. We have opioid substitution treatments like methadone maintenance program, like we have one in our JJ hospital where we are running one program of opioid substitution, that is being a buprenorphine. Here there is a role of directly observed therapy. That is, whenever the patient, whomever we are giving that opioid substitution, we call them daily or once a week to take the medication. That way we can monitor and motivate them to take. Now, the only problem we face with people living with HIV is sometimes some of the medication, that is ritonavir, nelfenavir, they are known to decrease level of methadone. So if the patients are on these drugs, we might have to give a higher dose than usual. And we have to treat the other comorbid psychiatric condition that the person is having. The other therapies, like in depression, like cognitive behavior therapy, support group model, is also useful. Specifically for substance use, there is also a role of motivational enhancement therapy and integrated treatment. Thus, we see there is a complex relationship between HIV and mental illness. They often have a shared risk factors, and commonly mental illnesses leads to non-adherence and any high-risk behavior. So whenever a person with HIV has mental illness, you need to see them in an integrated approach to ensure better treatment outcomes for them. Now, let's go for special population group. See, it becomes much more challenging for women because of the gender roles or the patriarchal system that we have. Or say in case of children or adolescents, I'm going to cover that in the next coming slides. For them, it is much more important for the clinics to be more hand-on. Children, if their parents also are seropositive, it's much more likely for them to have other mental health comorbidities. This is what research says. So say in children and adolescents, what are the warning signs? How do you know? You see, because in children, classically asking them, do you feel sad, may not be feasible. The children may not be able to express. So sometimes children may say that they persistently feel sad, or family members will say that they are withdrawn, like school nahi jata hai, yeah, they stay withdrawn, they don't go and play with other children, or they might hurt, or they might actually talk about death. And please do understand that children as young as 10 years have also committed suicide. So any child who talks about dying should be taken seriously. Often children, rather than complaining of sadness, could be very irritable, or could just behave in a very antisocial manner, could be behaving in a very out of control manner. They could have any drastic changes in mood, or the family members will say, "Ekdam badal gaya hai, uska swabhav hi badal ho gaya hai." We say change in personality or behavior. Or the child may not eat at all, or hardly eat anything, or eat only specific things. Like, typically eat only junk food. And the child might start losing weight because of that. Or the child may not sleep adequately. So they may miss school next day because they are not able to cover up their sleep. Or they may typically complain of pains, headache hota hai, peet mein dard hota hai. And so typically you will get academic problem. They can't concentrate in their studies and they miss school. So any warning sign, the child comes to you for follow-up, please do ask the family members if there is any change in their academics or their behavior. So now, what are the tips? Now, this all I was talking about was mental illness, but there is something called as mental health and well-being, which is about not having any mental illness. So specifically for persons living with HIV, I would like to talk about treatment adherence. You tell them that they should be regular in taking their treatment. You have regularly conversation about their mental health. You may not be having time, but you can just ask that, how are you feeling now? Are you feeling better? Discuss if they are using drugs, then ask them what is their current pattern of drug use. Then for the patients themselves, general health physically, the same we have for mental health. That is, people should have adequate sleep. Please, the recent lifestyle changes which we are having, sleeping late, getting up early, it doesn't work. They have to sleep well in the night. Smartphones, mobile phone usage, TV usage, screen time should be restricted, especially at night. Ask them to have a healthy, balanced diet. They should develop a what we call as a buddy system, someone whom they can trust in, a confidant with whom they can discuss what they feel, and of course, ask them to restrict their screen time. So to conclude, mental illnesses are pretty common in those living with HIV. It is often a contributing factor and of course causes poor outcome. It often causes barriers to treatment. They are not regular with treatment. Please, mental health screening is required. This is the main thing I would like to say. Trust me, diagnosing or suspecting or identifying depression is quite an easy task, and I feel it can be done bedside in the clinic itself. In fact, the PHQ-9, I would like to deviate a little bit from here. It originates from the Prime MD questionnaire. Now, Prime MD questionnaire has been translated to more than 10 Indian languages. And it is supposed to be used not just by psychiatrists or mental health professionals, but used not just by medical officers, but even, say, someone like counselors, nurses could use them to screen. Even Anganwadi workers could use them to screen people. Because depression being such a common illness, which is treatable and treatable at a very low cost. And if you treat it, the prognosis gets better. So it is important for us to identify a depressed person at the primary healthcare level. Please do not leave depression for a tertiary healthcare level. Tertiary healthcare level is of course for severe illnesses. It is of course there for depression, especially moderate to severe depression or depression with a history of bipolarity. The role of tertiary centers are there. The role of primary healthcare center is identifying depression because it is very common. Trust me, if you would screen in your clinic, you would find at least 20 to 30% have mild depressive symptoms. And check if these people are compliant or no. If they are not compliant, or any person whom you feel is not depressed also, but is not regular with your treatment, they follow up in the ART center, often become dropouts, or take half of the doses or miss most of them. Please do screen them for depression. PHQ-9 is a very simple questionnaire. It is available in Hindi. We can apply it in your setup. Even for a busy day also, remember at the end of the day, it is even a self-rated questionnaire in which the person applies it himself. And the key in the PHQ are the first two questions, which are the main screening question. That is, do you feel sad most of the days in the last 2 weeks? And two, do you feel decreased interest in whatever you felt I liked or enjoyed before in the last 2 weeks? So these are very two simple questions, which I think would hardly take 1 minute of your time. I feel you should incorporate it because patients who are depressed and get treated in a timely fashion, they have better prognosis. And last but not the least, I feel even at the primary healthcare center level, mental health services need to be integrated. Of course, now I am working in a medical college where we are working with a team. We have our big team here. So it is an integrated service, but it would be a great if it is even integrated at the district, taluka, and even at the primary care level. So thank you for the presentation. And yes, I forward to.
Yeah, thank you so much, ma'am.
Yes.
Yeah, we have 2 questions in the chat box, ma'am. If you can just have a look at them. Meanwhile, we'll quickly run through the post test. Kiran sir, can we have the post test? Thank you. All the participants are requested to attempt the post test as well. The questions are visible on your screen now. Ma'am, I'll read out the questions from the chat box. How to differentiate hand and depression or dementia, whether administration of psychopharmacological molecule will help in case of hand. Ma'am, you're on mute.
Yes. I'll answer now. Is the poll over?
It's going on, ma'am. We can.
Should I answer now or later?
Yeah, you can answer now, ma'am. Yes.
Yes, that's a very interesting question because neurocognitive disorders are very frequently mistaken with depression. Okay. So now again, let me come back to it. See, for depression, some symptoms in depression will be overlapping. So decreased energy, impaired appetite and sleep are not classic of depression. For depression, ask the classic symptoms: feeling sad or not feeling anything at all. Secondly, feelings of guilt, feeling hopeless. These are very classic depression symptoms. So a person who is become family members, for hand, the milder ones, family members will complain that they have become very dull or quiet. Now again, dull and quiet could have impaired concentration, could be having, which is an overlapping symptom with depression. But if you talk to them, classically, they will say they feel sad, they feel unhappy, or they don't feel anything at all, or they are unable to experience any emotion. So that will be more classic of depression, along with feeling of, if they have feeling of guilt or helpless or hopeless, that is classically depression. Whereas for mild cognitive disorders, for hand, the milder ones, typically their problem will be with concentration. There are certain even bedside techniques you could try. There is this trail making test, you ask them to link A with 1, B with 2, or there is a simple test like, for checking their concentration or attention. You can do a digit span, like you tell them digits and up to 7, start with 2, then 3, then 4, and see whether they can say the digits properly forwards also and backwards also. So classically, people with cognitive problems will have difficulty in saying them. For patients who are not so educated, you could just do with months or days. Like tell them say Monday, Tuesday, Wednesday, Thursday, or say it ulta, Sunday, Saturday, Friday. So that you can differentiate from mild cognitive, like bedside, you could just examine without any neurocognitive test. And for dementia is much more severe. So the forgetfulness will be much more marked. And classically, the forgetfulness will be for recent. So past, they will remember everything. They will remember their school time, that when they used to go to work. But the recent ones, they won't remember. See, classically, what we see in psychiatric practice, dementia is seen in geriatric population. But in case of PLHIV who are having comorbid neurological conditions, the dementia can come earlier, even in young age, in which I understand it could be difficult to differentiate between depression. So in this case, what you see in case of dementia, the classical features won't be just sadness. They will have difficulty in remembering things, especially new ones. See, in depressed persons, classically, if you ask them, there will be a lack of trial. So they will say, I don't remember. Mujhe malum nahi hai, mujhe yaad nahi. Whereas a depressed person will at least try to attempt. So that will be a very classical symptom, I will say. How you differentiate from dementia. And our classical MMSC or the Hindi mental status examination, also you can apply for dementia. You will get a score of 23 or lesser. You should suspect dementia. The next question I think the person asked is whether any psychopharmacological molecule will help. Yes, but before that, first, people who are not regular with ART are more likely to develop, or a person with comorbid neurological opportunistic infection is more likely to develop neurocognitive disorder. So first rule out that. If that is ruled out, then yes, molecules, especially memantine is quite useful. Memantine used between 5 to 20 mg. You could also give donepezil between 5 to 30 mg. Yes, so I answered the first question. The second question?
Yes, ma'am. Ma'am, what are the common drug-drug interactions with TLD regimen with various psychiatric drugs?
What are the common? Yes, sorry.
Yeah, what are the common drug-drug interactions with TLD regimen with various psychiatric drugs?
Yes. Amongst these, amongst psychiatric drugs, okay, are mood stabilizers, or which is commonly known as anti-epileptics. They are the most likely. Especially you need to take care of the cytochrome P450. Is a very common metabolic point for both the ART as well as our psychotropics. Amongst these inducers, okay, especially carbamazepine and fluoxamine. These are two top psychiatric drugs which interfere with the ART regimen. Amongst antidepressant class of drugs, as I told you, fluoxamine is not preferred, but sertraline and escitalopram, these are very safe. They have very less drug-drug interaction. Amongst tricyclic antidepressants, as I told in the slide, amitriptyline is a very good molecule. Even imipramine is good. Only thing you need to do ECG monitoring. About other molecules, that is, say, benzodiazepines, which we give, drug-drug interactions is there, but at lower doses in which we give 0.5 of clonazepam, or say if you are giving alprazolam at 0.25, 0.5, it is quite safe. Amongst antipsychotics, most of the antipsychotics have very low drug-drug interaction, except for we need to look out for any impairment in LFTs. Other drug-drug interactions are not there much. Mainly these are mood stabilizers, which need to be given very carefully. There is a very high likelihood of derangement in the LFTs, especially with carbamazepine or divalproex. High risk of hematologic side effects in carbamazepine, and other molecules are comparatively safer and they could be given along with it.
Thank you, ma'am. Next question. How long should one take antidepressants?
Yes, this is a crucial question. I think I did not cover it in my talk. See, antidepressant needs to be given for a minimum of 6 to 9 months. And this is across the board, even for people, not just for PLHIV, for others also. Because depression is a very slow illness. Please keep in mind, even when we start antidepressant, the effects are first seen in 2 weeks. And the optimal effect is seen between 6 to 8 weeks of starting and escalating the dose. So after the first episode of depression, yes, treatment should be given for minimum 6 to 9 months. Why? Because that is given as a maintenance treatment. Chances of relapse are extremely high. As I told, 50% of people with depression have a second episode of depression within the next 5 years. So at least 6 to 9 months, it should be continued. Similarly, apart from depression, I would also like to add other illnesses of ours, like say psychosis, anxiety disorders. Most of them have treatment for a minimum of 9 months, which you should give the treatment. Again, a second ground rule, this is for first episode of mental illness. For anybody who's having a second episode of mental illness, that is a second depressive episode or a second psychotic episode, then we recommend treatment should be given at least for 2 years. And people who develop a third episode, especially psychosis and depression, okay, or bipolar mood disorder, for them, we give treatment for minimum 5 years or even beyond. So yes, it goes on long along with ART. And anytime you suspect that there could be a possible drug-drug interaction or there is a worsening in their condition or the worsening of the mental illness, you can always take a referral.
Next question, ma'am. SMD leading to HR behavior and contracting HIV versus diagnosis of mental health issues as a reaction to a primary diagnosis of HIV. Which one is treated better with psychopharmacology? Sorry, that's a big question.
Yeah. No, it's a trick question because it's very difficult. See what happens. Again, as I was telling you, mental illness itself predisposes to HIV. And HIV, the illness itself, as well as the comorbid conditions, the medication, that all predispose to mental illness again. So that is difficult to say which predisposes the next. Again, I will say we have a stress diathesis model. That is, a person who is basically vulnerable to mental illness, when they are under a stressful situation, are more likely to develop mental illness. So a person who is initially only predisposed. So even if the diagnosis is coming after getting the diagnosis of HIV, still it matters the same way. Now, one point you ask, what if the diagnosis, the symptoms come immediately after diagnosis? See, if the symptoms come immediately after diagnosis, then remember it is a reactionary one. And for reactionary one, always the role of not just psychopharmacology, but also behavioral or psychological interventions are important, because the person is trying to adjust to a new diagnosis or trying to adjust to a new worsening or a new psychosocial problem that they are facing. Okay, versus we call something as an endogenous depression. That is a person when everything is going on fine, they start developing mental illness. The medication dose is same, everything is same. They have an endogenous depression. Again, if you ask me prognosis, which is better, reactionary is always better than a in vivo or a endogenous. Yes.
Yeah, ma'am, there's another question.
Yes.
Should PHQ sorry, should PHQ-9 be applied all PLHIV, or is there a specific age criteria?
See, PHQ-9 can be applied for all ages, but you should ideally apply it. I mean, in the brochure, it is mentioned for adults, not really for children. But adolescents, yes, you can apply. And for children, again, if you see the first two questions of the PHQ-9, is something most children could also see. So yes, you should apply to, I would say, all age groups, or take it as the 4 questions for which you could even frame questions for younger children. I know it seems a little difficult. People don't find it difficult to understand that, children don't answer these questions. But trust me, even 7-year, 8-year-old children have discussed with us and told they feel sad. They don't feel good. They feel, even 9-year-olds have talked about death with us. So yes, even they can answer the questions. So yes, you should apply for all age groups.
What about hypothermia if a PLHIV is suffering from and misdiagnosed as mild, moderate, or severe depression?
For
Thymia.
See, now, I wouldn't say hypothermia, but there are, in clinical basis, no? See, there is a basic difference between personality and illness. See, somebody's personality could be hyperthymic or hypothymic. Hyperthymic personality means a person is very outgoing, extroverted. Whereas a hypothymic would be more quiet, remaining aloof to himself, or to not be having intense emotions. They are quite a little better controlled in emotion. Now, that is definitely different from depression. That's why you need to get to their baseline. When we ask the question, okay, the second question which we are asking in PHQ, okay, that do they experience pleasure in things they liked before? That is the crux, no? So you ask them, pehle kya acha lagta tha? So they will say ki TV dekhna acha lagta tha. So you're comparing with that. So if a bi-person personality was hypothymic, they would say, mujhe ye cheez hai na, everybody likes something. Or they might say, mujhe na akele baith ke kitab padhna acha. So you ask them, do they like that before? Like before? Do they enjoy that same activity like before? And they might say they don't. So that's how you differentiate. Yes.
Thank you, ma'am. HIV stigma. With HIV stigma, PLHIV goes under depression, referring them to psychiatric treatment. It will again be one more stigma for them. So I would like to know how to motivate them for the same.
Yes, actually, if you go to see in clinical practice, this is the most common. Most physicians tell us that we refer patients to you, but they refuse to come. I know it's a double whammy of sort. As I told you, they are already having 2 diagnoses. They are PLHIV and they are having mental illness. So already they are in for a little worse prognosis. So difficult as it may seem, but we might have to try and push them that this is help that you are seeking for everyday issues. You could initially start with maybe, the person being referred to the counselor itself. I believe most of them are talking with the counselor. So the counselor themselves could also intervene and say that it is a more modified or a more specialized form of what is happening already in the center, that they are seeking help. Like, if our head pains, we go to a doctor. So the same way, if you're not feeling good, you're feeling sad, we go to another one. So yeah, I understand what you're saying. It is difficult because people have a lot of stigma. But yes, they should visit. And trust me, if you visit any of our centers, all the medical colleges in India have a psychiatric setup. And trust me, our centers are as crowded as any other OPD in our college. So yes, you need to make them break the barrier. Convince them. It may not happen in the first visit, but try to convince. Most people do try, and yes, they do follow.
Thank you so much, ma'am. We have covered all the questions from the chat box. Any more questions? Participants are requested to please unmute their mic, or you can again type in the chat box. Ma'am, I don't think there are any questions. I'll quickly show the answers for the pre and post
Yes,
test
please.
questions. I hope the screen is visible. The first question was mental health screening is recommended before starting ART. So which is the screening tool that is used? It is PHQ-9. Confusion and fluctuating sensorium is seen in delirium. Third question, SSRI are recommended in which psychiatric disorders? It is all of the above. So that is anxiety disorders, depression, and dementia. Which is the most common psychiatric comorbid diagnosis in PLHIV? It is depression. And why is it important to identify and treat depression? Because all of the above, that is improves treatment adherence, it leads to lower cost of healthcare services, and it also reduces high-risk behavior. Thank you so much, ma'am, for facilitating today's session.
Thank you for giving me this
Thank you, ma'am, for the wonderful session. Thank you to all the participants for patient listening and participating in this session. We'll conclude this session now. Thank you, ma'am.